Good morning, everyone. So today we will be discussing about the new approaches to manage portal hypertension in advanced diseases. So this is a schematic diagram for the first years who have recently joined. This is the hepatic circulation, as you can see, and there is increased production of the endothelin 1, which is a potent vasoconstrictor, and decreased production of the nitric oxide, leading thereby vasoconstriction in the hepatic microvasculature. On the other hand, this is splanchnic circulation, where there is increased production of nitric oxide, leading thereby vasodilatation and splanchnic hyperdynamic circulation. So two contrasting things are happening here. In the hepatic microvasculature, there is vasoconstriction, and in splanchnic circulation, there is vasodilatation. So this is my outline of presentation. Coming to the normal hepatic microvasculature, as you can see, this is the endothelial lining, which is having fenestrations, and there is no basement membrane here, so as to allow the easy passage of the macromolecules from these sinusoids into the virtual space of DC, which is the space in between the sinusoidal lumen and the hepatocytes, wherein reside the stellate cells and the Kupffer cells. And this important function of the endothelium is the secretion of the nitric oxide, which happens because of the increased activity of the eNOS through the VEGF. And this nitric oxide is very important, and as it helps in maintaining these fenestrations, and also it helps in prevention of the platelet microthrombi, platelet aggregation into the endothelium, and also helps in maintaining the HSC, the stellate cells, in the quiescent state. And this is what happens in the cirrhosis and portal hypertension. There is defenestration of the sinusoids, as you can see here. There is activation of the stellate cells and the deposition of the collagen in the space of DC. Various etiologies, whether it is alcohol, drugs or virus, and so on and so forth, the ultimate final common pathway is the increase in the fibrosis in the hepatic sinusoids in the space of DC. It happens because of the increased inflammation to the formation of the neutrophil extracellular traps and the microvascular thrombosis. And ultimately, it leads to the constriction in the contractile cells, that is the stellate cells and the sinusoidal endothelial cells. Ultimately, the final common pathway of the vasoconstrictors and the vasodilators is the complex formation between the actin and the myosin. And two enzymes are there, the myosin light chain kinase and myosin light chain phosphatase. The kinase leads to phosphorylation of the myosin light chain and activation, which in presence of the actin, in presence of the calcium and the calmodulin, forms the complex with the and formation of the ectomyosin, and it leads to contraction, as you can see here. And the Rho kinase pathway and the angiotensin 2, they are the two important mediators which cause the contraction by the increasing the activity of the myosin light chain kinase. On the other hand, the vasodilators such as nitric oxide, it leads to increased production of the cyclic GMP, which causes activation of the phosphatase. It removes the phosphate group from the myosin light chain and inhibits the interaction of the actin and myosin, and ultimately leads to vasodilation. So the vasoconstrictors and the vasodilators act through the activity of the myosin light chain kinase or the phosphatase. And the first thing to happen in the portal hypertension is the intrahepatic vascular resistance increase, which happens because of the abnormality of the liver sinusoidal endothelial cells, the stellate cells, or the hepatic macrophages, which leads to microcirculatory dysfunction. Because of the structural changes, these are the static changes, they contribute nearly 60% of the component of the portal hypertension. And the dynamic changes, that is the imbalance between the vasoconstrictors and the vasodilators, ultimately leading to increase in the hepatic microvascular resistance and portal hypertension. Two important laws of physics are there in portal hypertension. Number one is the Poiseuille's law, that resistance is equal to 8 eta L upon pi R4. That is, resistance is inversely proportional to the fourth power of the radius of the blood vessel. So if there is vasoconstriction in the hepatic sinusoids, it will lead to increase in the resistance, raised to the power 4. So there will be exponential increase in the resistance. For example, if the radius of the blood vessel is decreased by just 2%, then the resistance will increase to the extent of 16%. So there is an exponential relationship between the diameter or the radius of the blood vessel and the resistance. And the second law is the Ohm's law, that is portal pressure is a product of hepatic vascular resistance. This we saw in the Poiseuille's law into portal blood flow. So this happens in the extrahepatic circulation, that the portal blood flow is increased because of the splanchnic hyperemia, vasodilatation, and ultimately leading to the increased portal pressure, and finally leading to various manifestations of the portal hypertension that we see routinely in our wards. The therapeutic approaches to portal hypertension can be first to treat the cause and then anticipate that there should be reduction in the portal hypertension, and or treat the portal hypertension directly, treat the extrahepatic factors or treat the intrahepatic factors. Now coming to treatment of the cause and predicting whether this causes regression of the portal hypertension or not. So in animal studies, it has been shown that if we treat the cause, the portal hypertension regresses. But it has also been seen, sometimes it happens, especially in the advanced decompensated liver disease, that even if we treat the cause, the portal hypertension persists and can even progress. So it is important to identify what are the predictors who will predict if we treat the cause, the portal hypertension will regress or not. So several studies are there. So for example, in this study, analyzing the largest collateral, if the diameter is more than 7 millimeter, or the flow velocity is more than 15 centimeter per second in that collateral, or the volume more than 500 ml per minute, it indicates advanced portal hypertension, meaning thereby that this is not going to regress just by treatment of the cause. On the other hand, if there is reduction in the diameter of the largest collateral to 3.6 millimeter, it is a favorable response, and we can anticipate the regression in the portal hypertension by treating the cause. Also, in another study, absence of a large collateral more than 9 millimeter at baseline is a favorable factor, and reduction in the LSM or the SSM per percentage decrease in the LSM leads to nearly 3% chance that there will be HUPG reduction by 10%. And in another study, low baseline MELD score less than 13 is a favorable predictor of regression of the portal hypertension by treating the cause. Now coming to the interventions targeting the extrahepatic factors, which are the mainstay of treatment as of now. Most important one among these are the beta blockers, the non-selective beta blockers. The propranolol, it causes blockage of the beta-1 and the beta-2 receptors. Beta-1 is present on the heart. It leads to reduction in the cardiac output and the heart rate. Beta-2 is an interesting thing that it blocks the beta-2 receptors in the splanchnic circulation. Thereby, the alpha receptors remain open, and then the catecholamines then can act on the alpha receptors and bring about the splanchnic vasoconstriction. This is somewhat similar to that of midodrine, because midodrine also acts directly on the alpha receptors, and the non-selective beta blockers indirectly act through the alpha receptors, and thereby it causes reduction in the splanchnic blood flow. Carvedilol has an additional alpha-1 adrenergic antagonistic action. It causes decrease in the intrahepatic vascular resistance, so there is more reduction of the portal pressure here. On the other hand, since alpha receptors are also present on the systemic blood vessels, it causes decrease in the systemic vascular resistance and hypotension, which can be detrimental, especially in the advanced stage of the portal hypertension. Also, non-hemodynamic beneficial effects of the beta blockers are there. It increases intestinal motility, decreases bacterial translocation, decreases inflammation, and also then subsequently brings about beneficial effects irrespective of the decrease in the HUPG. So, it has been seen that there is a therapeutic window for the action of the beta blockers. They are not effective in the initial stages of the portal hypertension, and they are detrimental in the advanced stage of the portal hypertension. It happens because in the natural history of chronic liver disease, it starts from fibrosis, then compensated advanced chronic liver disease, then CSPS, then varices, and then decompensation. Since beta blockers act primarily on the splanchnic circulation, then it means that if it is increased, if there is splanchnic hyperemia, only then they are going to work. So they are primarily acting when there is presence of the clinically significant portal hypertension, HUPG more than 10 or the LSM more than 25. And once the disease is advanced to a fairly large extent, because of the splanchnic vasodilatation, the cardiac activity is at its maximum to maintain the perfusion pressure. And if that sympathetic drive is inhibited by the beta-1 antagonistic action of the NSBB, then it can lead to detrimental effect, compromising the organ perfusion, especially the kidneys, and can lead to AKI and other multi-organ failure and can be detrimental. So there is a therapeutic window phenomena, and also it has been seen that these beta blockers are more beneficial in the presence of small varices, irrespective of the presence of CSPH or not. It has been shown in various studies, even in the Predisky post-hoc analysis, it was seen that they are less effective if there are no varices, but more effective if there are small or large varices. But since they can be detrimental in the advanced stage of portal hypertension, so this is a window for the activity of the non-selective beta blockers, and this window closes earlier for the carvedilol because of its potent hypotensive effects. So midodrine remains an option because it can attempt to reopen that window because it does not act on the beta-1 receptors on the heart. It specifically acts on the splanchnic circulation. It causes splanchnic vasoconstriction, increases the blood pressure, and increases the renal perfusion. So this was a pilot study which was done in our institute, where the patients who are having relative or absolute contraindications for the beta blockers, the decomposite cirrhosis or the ACLF, they were given midodrine and 10 milligram, and then HUPG was assessed 3 hours after that. And in this study, it was found that there was a significant reduction of the HUPG in patients of decomposite cirrhosis, reduction by nearly 7%, and in ACLF patients, reduction by nearly 9%. And the HUPG response, which was the primary outcome of this study, was seen in nearly 10% of the patients of decomposite cirrhosis and in 26.7% patients of ACLF. And interestingly, it was found in this study that increase in the MAP by 8.5 millimeter of mercury had a fairly good AU-ROC and a good specificity of 92% in predicting the HUPG response. So the MAP measurement can be a useful bedside tool to assess whether this patient is going to respond to midodrine with regard to HUPG response or not. So this was a RCT which was done in our institute, where midodrine plus propranolol was compared with propranolol alone in patients with cirrhosis and severe ascites. And the primary outcome of this study was the incidence of the vessel beat at the end of 1 year, which was significantly less in the combination arm compared to the propranolol only arm. And also there was significant reduction in the HUPG in both the groups, as we can see here, but the reduction was more in the combination arm compared to only propranolol arm. And the responders of HUPG were also significantly more in the combination arm compared to only propranolol arm. And among the various secondary outcome parameters, it was a favorable response with the midodrine plus propranolol group with regard to the number of paracentesis or the PICD or the SBP, resolution of the ascites, reintroduction of the diuretics, and a high dose of diuretics could be given in the combination arm compared to the propranolol only arm, and there was also reduction in the grade of varices in this study. Now coming to targeting the intrahepatic abnormalities, the most important one among these are the anticoagulants. This is a fairly old study, but a very famous study in which enoxaparin was compared with placebo in patients with advanced cirrhosis B7 to C10, and the primary outcome of this study was the prevention of the portal vein thrombosis, which was of the enoxaparin was given for 48 weeks, and the primary outcome was analyzed at 96 weeks. And it was seen that none of the patients who received enoxaparin had portal vein thrombosis. And also, more importantly, the probability of decompensation at the end of 96 weeks was less in patients who received enoxaparin, and also the probability of survival was also more in patients who received enoxaparin. Among the liver functions, it was seen that compared to a baseline at 48 weeks, till the time that the patient received enoxaparin, there was a significant reduction in the bilirubin, albumin, and the INR. But when the enoxaparin was stopped at 48 weeks and then at the 96 weeks, it was seen that they returned back to the baseline, again indicating the favorable effects of the enoxaparin in this group of patients. Also, it improved the bowel health. For example, this is the intestinal fatty acid bonding protein, which is a marker of the intestinal enterocyte death. It reduced significantly by 48 weeks. The markers of inflammation, IL-6, also reduced. The 16S ribosomal DNA, the markers of microbial translocation, also reduced in the enoxaparin arm at the 48 weeks. And the soluble CD14, which is marker of the host response to the microbial translocation, also reduced in the enoxaparin arm. But there are very little studies analyzing the role of anticoagulants in patients with cirrhosis. So this was an individual patient meta-analysis comprising 5 studies. But only one of these studies was prospective study, 4 were retrospective, and none of these study was a RCT. All these studies have shown that the anticoagulants are showing a beneficial effect with regard to the resolution of the thrombus, and also they are safe in patients with cirrhosis. However, with regard to the improvement in the mortality, there is a conflicting data as of now. So this was a meta-analysis of individual patient, 5 studies, 500 patients, and in this study it was seen that the all-cause mortality was significantly less in patients who received the anticoagulants. Interestingly, the anticoagulants median duration of treatment was just 9 months, but the favorable effect was seen till the 26 months as well. So there was a prolonged beneficial effects of the anticoagulants in this meta-analysis. Also in this study, it was found that the beneficial effect of the anticoagulants was seen irrespective of the severity of the portal vein thrombosis and whether the portal vein thrombus recanalized or not. So the beneficial effect was there even in those group of patients in which the portal vein thrombus did not recognize. So this is a second RCT in the field of portal hypertension, analyzing the effect of the anticoagulants. And the first RCT to assess the response to the newer anticoagulant, the rivaroxaban, in preventing the complications of portal hypertension in the siroxaban study. It is published just now. Unfortunately, the sample size of this study was 180 patients, but the recruitment was very slow. Only 90 patients could be recruited and then analyzed. And even in those patients who received the rivaroxaban, although the sample size was not achieved, still there was a tendency for the improvement in the survival. As we can see here, the primary endpoint was the first liver decompensation or the death or liver transplant, whichever comes first. So there was a tendency to have better survival in the patients who received rivaroxaban. Specifically, the outcome was very favorable in the Child-Pugh 7 state, where the beneficial effect could reach the statistical significance, indicating that the anticoagulants, if are to be given, should be given in the earlier stage of the portal hypertension and not in the later stages. So there is a major research gap with regard to the use of anticoagulants in the cirrhosis. Only 2 RCTs are there. The first RCT was nearly 10 years back by the Villa study, and the second RCT just now published, but that had to be, the patient recruitment was very less. And it is in stark contrast to the anticoagulants which are analyzed in patients with atrial fibrillation or the cardiovascular disease, for the thromboprophylaxis, or the fracture patients for the thromboprophylaxis of the embolism, where several thousands of the patients have been studied. But in this study, the cirrhotic patients have been specifically excluded for the fear of the negative outcome of these studies. And therefore, this is an unmet need, the use of anticoagulants in the cirrhosis, and should be explored further. Coming to statins, they have got tremendous promise. In various clinical evidence is there. In that, it reduces the macrophage activation. It has got an anti-inflammatory effect. It causes upregulation of the KLF2, thereby increasing the nitric oxide production and decreases the collagen production and decreases the fibrosis. Therefore, it increases the endothelial function and increases the nitric oxide levels. So it has got a role to play in portal hypertension as well, apart from its effect in reducing the risk of SCC. So this is how the statins work. They act primarily on the 2 cells, the sinusoidal endothelial cells, where, as we see here, this is ET1, endothelin 1, which binds to the ETB receptor. ET1, when it binds to ETA receptor, it causes vasoconstriction, which is the pronounced effect of the endothelin. But it is also important to note that when it binds to the ETB receptor, it causes vasodilatation by phosphorylating the AKT, and statin causes the increase in the phosphorylation of the AKT, and subsequently causes increased phosphorylation of the eNOS, thereby increasing the production of nitric oxide and bring about the vasodilatation. Also, they act on the stellate cells, where they inhibit the activation of various fibrosis-related genes and ultimately cause favorable effects in the portal hypertension. And at the more basic level, they cause inhibition of the farnesyl pyrophosphate, which has got an anti-inflammatory effect. And also, it causes inhibition of the Rho kinase pathway by reducing the activity of the gynanyl pyrophosphate. This Rho kinase, as we had just discussed, is a very important player in the field of portal hypertension, because it causes increase in the hepatic fibrosis, and also it causes increase in the interaction of the actin and myosin by causing phosphorylation of the myosin light chain. So it causes, if this pathway is blocked, it causes reduction in the portal pressure. And also it causes, statins remove the inhibitory effect of the Rho kinase pathway on the KLF2. And this removal of the inhibition causes increased activity of the eNOS pathway and causes increased production of the nitric oxide. So statins act both on the fixed component as well as the dynamic component of the portal hypertension. So this is a very famous study, the BLAPS study, published nearly 10 years back, analyzing the effect of the simvastatin to the standard therapy in the prevention of the vessel rebleeding and on the mortality. The primary outcome of this study was the composite of the proportion free of bleeding or the death, which was not different compared to the placebo in this study. However, when it was analyzed the proportion free of death, the statins had a survival advantage. And in this study, it was found that nearly 22% in the placebo group died compared to 9% patient at the end of 24 months. And the effect was more seen in the child A and B, but not in child C. So again, emphasizing, just like the anticoagulants, the statins may be more effective in the initial stage of the liver diseases. And the proportion free of bleeding was similar, but there was mortality benefit, indicating that maybe the statins reduce the severity of the vessel bleeding, so the outcome of that bleeding is not as serious. So this is Rajan's study, which published from our institute, where the hemodynamic effects of adding simvastatin to carvedilol was analyzed, and the primary outcome of this study was the incidence of the vessel bleeding or the HBG response at the end of 3 months. Although it was not statistically significant, but there was a numerically greater HBG response, 61% compared to 58%. Although this is a negative study, but certain things are to be highlighted in this study. The sample size was 110 patients in each group, but not all of these patients, as we can see the denominator, could achieve the HBG response. Although in this study, the ITT analysis was also done. And nearly 50% of these of these patients were having NASH-related chronic liver disease. And as we know now that the NASH has got a pre-sinusoidal component of portal hypertension as well, which may not be reflected by measuring the HEPG. So we cannot completely rule out the positive effects of the simvastatin in these patients. And this is a very recent study where the hemodynamic effects of the carvedilol plus simvastatin were compared to carvedilol plus placebo, and the primary outcome was the HBG response at the end of 4 weeks, where, as we see, it was seen in significantly more patients. The reduction was more, that is nearly 3 compared to 2 in the simvastatin plus carvedilol group, and the HBG response was seen in significantly more patients in the combination arm compared to only carvedilol. Interestingly, in this study, when the second HBG was done, they also gave a test meal and analyzed whether this HBG, what is the impact of HBG, impact of carvedilol and simvastatin on the HBG. And as we know, whenever we take food, there is splanchnic hyperemia, the portal pressure increases because of increase in the blood flow. And this is the reason that the incidence of variceal bleeding are more commonly seen in the late night or early morning. And this is one of the reasons that the beta blockers should be given more in the night compared to the day, because the incidence of bleeding is more, and also to negate the hypertensive side effect of the beta blockers. And interestingly, in this study, it was found that the simvastatin plus carvedilol group patient attenuated the rise in the portal pressure by nearly 12% compared to 23% in the carvedilol plus placebo group. So this is a very interesting and novel finding, because repeated increase in the portal pressure postprandially will lead to production, formation, and the enlargement and subsequent rupture of the varices, and also the other complications of portal hypertension. And this effect of simvastatin has not been addressed before. Also, the inflammatory markers were reduced significantly in the carvedilol plus simvastatin arm compared to only carvedilol arm. So this is a very recent, where the primary outcome was the HBG response, and as we see here, there was a modest reduction in HBG by 1.1, although it was significant, but there was no effect of the statins on the incidence of variceal bleeding or the recurrent ascites or any mortality benefit. It was not there. Because as of now, few studies have been done with regard to statins in the field of portal hypertension, and there have been heterogeneity with regard to the dose and the duration of the treatment, the patient selection, and also the statin, whether it should be hydrophilic or the lipophilic. It is still a matter of debate. Now coming to the role of antibiotics, because we know that there is a role of inflammation, the gut bacterial translocation in causing portal hypertension, but there is very little data with regard to the antibiotics in reducing the portal pressure. This is one RCT. This is one meta-analysis comprising 5 studies, but all of them have been retrospective, and there was no benefit of using antibiotics in anticipation of the reduction in HEPG. And when the subgroup analysis was done, then it was found when the antibiotics were given for more than 30 days, some amount of benefit was there, but clearly there is no concrete data as of now to suggest any positive role of antibiotics in reducing the HEPGs. And also comparing the rifaximin versus norfloxacin, there was a slight advantage of rifaximin over norfloxacin, but that was also not statistically significant. Now coming to the role of metformin, because metformin is also a pleiotropic drug, just like statins, and has got positive effects on the vasculature and also the cell cycles. And this is a very famous study by Dinesh from our institute, where it was found that metformin reduces the hepatic resistance in the CCL4 model as well as in the CBD ligation model of the cirrhotic rats. And it was seen that the portal pressure reduction was seen in the metformin compared to vehicle by nearly 23%, and which was additive to that of the propranolol. And this leads to the reduction in the hepatic vascular resistance, but it did not lead to any reduction in the portal blood flow, meaning thereby that they primarily act on the hepatic microvasculature and not on the splanchnic circulation. So it also led to the increase in the nitric oxide level and reduction in the peroxide ion. And it did not modify any activity of the eNOS or the AMPK pathway, indicating that it is not the increased production of the nitric oxide, but it is the decrease in the scavenging of the nitric oxide by the metformin because of its antioxidant effect, which led to the increase in the nitric oxide levels. And also it led to the reduction in the fibrosis and reduction in the activity of the stellate cells and reduction in the activity of the Rho kinase pathway. The phosphatidylmyosin myosin upon myosin is a surrogate marker of the Rho kinase pathway, so it led to reduction in the various aspects of the portal hypertension. Now, there is only one study analyzing the effect of metformin on the portal pressure. 32 patients were there, 16 in the placebo arm, 16 in the metformin arm, and the effect of 1 gram of metformin was assessed on HVPG after 90 minutes of the study. And it was seen that it led to 16% reduction in the HVPG, which was statistically significant. And HVPG response was seen in 46% of the patient compared to 8% in the placebo arm. So this is a very recent study by Dr. Garvit, just finished, and in which the HVPG response was seen in the carvedilol plus metformin arm compared to carvedilol only arm. 72 patients were analyzed, and at the end of 90 minutes, it was seen that the primary outcome, that is the HVPG response, reduction by more than 20% or reduction to less than 12, was seen in significantly more patients in the combination arm compared to only carvedilol arm. And the HVPG reduction was seen to the extent of 37% compared to 22% in the only carvedilol arm. As of now, there is some preclinical evidence for the activity or positive effect of the Rho kinase inhibitors and the angiotensin II inhibitors or other nitric oxide donors and endothelin antagonists. And there is small clinical evidence of the positive effects of the endothelin receptor blockers, ascorbic acid, FXR agonist, and the phosphodiesterase 5 inhibitors. And some of the studies have been negative as well, but these are very small, little evidence as of now. So to conclude, portal hypertension is a multifaceted pathology, and the development of the hepatic microcirculatory dysfunction and the hyperdynamic splanchnic circulation play an important role. Non-selective beta blockers till now have been the backbone of the treatment, but also need to consider the therapeutic window phenomena. New pathophysiological targets with high potential to modify the clinical course are in the focus, and there have been several therapeutic interventions which have shown the ability to mitigate this portal hypertension. And still there is a room to better characterize who of these patients are going to respond and who are the patients who could have the most benefit from these emerging treatment options. And finally, RCTs are really needed and with the hard clinical endpoints for translating these medicines into clinical practice.